Hello. So my name is Fran Balamuth. I am a pediatric emergency medicine physician in Philadelphia, PA, in the East Coast of the United States. And I'm excited to share with you today some words about pediatric sepsis using digital support systems. I have no financial disclosures. And what I'm going to talk about today largely is thinking about sepsis recognition in the emergency setting. So kind of in the grand group of kids who come to the ED largely with fever. And we'll show you some of the recognition tools that are used currently, largely across the United States. And then we'll start to think about what are the next steps. So if we're going to move these recognition tools into the next decade, what are some things that we should think about? And those include things like, can we use these tools to improve equity in sepsis care? Can we have a better reference standard so that we know exactly what we're screening for? Can we use machine learning to augment some of the tools that exist now? And how do we incorporate human factors into thinking about building the smartest types of tools? And then finally, thinking about whether some of these tools can be utilized outside of these high resource, high tech type settings. So we'll start with a case. So I think this is a challenge that faces really anyone trying to take care of children. So there's a 3-year-old patient who's sitting in the waiting room who has a high fever. He is tachycardic and a little bit tachypnic, but the blood pressure is normal and saturations on room air are normal. And 99.99 times out of 100, an hour later, after you've given the child some fever medication and some oral PO challenge, you have a child who looks like this, who has a self-limited viral illness, goes about their life and all is well. But every once in a while, kind of hiding in these patients is someone like Rory Staunton. So this is a healthy child who's not 3 years old, but he was 12 at the time, who presented to an emergency department in the US and had unrecognized sepsis. Was initially sent home with what was thought to be a viral illness, and then came back the next day in extremis and ultimately died of septic shock secondary to group A strep. And so I think lots of us in emergency care, or really pediatrics in general, lose a lot of sleep over not wanting to send children like Rory Staunton home with unrecognized sepsis. And so we've tried to build tools to help us recognize these patients. But the challenge is that these patients are rare, right? So in our emergency department, for example, we see over 100,000 visits every year. About a quarter of those are for something that has to do with infection. And really only, 1 in 1,000 of those require ICU care for shock and organ dysfunction. So really, sepsis is rare, and we are kind of trying to find a needle in a haystack. And so this is kind of the conceptual model that I have built my career around, which is saying that we have a sea of febrile kids in the ED. Very few of them are going to go on to be critically ill with sepsis. And what are the kinds of tools that we can use to improve stratification of risk for these children? And so I think I'm not really going to talk today about are there things we know about children before they even show up for care based on their genetics and their medical history. I'm going to focus mostly today on things that we know when children first show up in the first 5 minutes of their ED care, like their vital signs, their mental status, and their perfusion. And then I'll talk a little bit about are there additional elements that we can add with information that we learn kind of throughout the course of their stay with us in the emergency department. And when you think about kind of the challenges of building these sepsis screening tools, and should we build electronic alerts or computer-based tools to help us find these patients, I think we argued a lot in the beginning that electronic tools actually were not ideal for this. Tools that were based off of vital signs they would find too much hay and too few needles because these alerts are sensitive, but we know that most kids who have, tachycardia in the setting of fever are going to be fine. And so we don't want to, put all of these high resource needs into these children where most of them are actually not going to benefit from them. At the same time, I think using clinical judgment alone, which is saying, we're going to recognize these kids based on our own clinical acumen and kind of more human, the more human side of things, we know that we're probably going to miss some patients that way, but that we will gain specificity. And so we kind of want to find the sweet spot tool that can kind of use technology to its advantages, but at the same time, remember that we do actually need people to make some of these decisions. And so we kind of thought about that when we built our alert and came up with this kind of 2-stage alert that we hope kind of takes advantage of both of these elements. So the first thing we did, and this is almost 10 years ago now, was to say, should we have an alert at all? And so we had kind of the protocolized sepsis care that we put into place over the course of a couple of years in our emergency department. And I think we thought that, we are at a highly specialized pediatric center. We're good at the bedside. We can do this on our own. But it turned out actually that we were missing almost 30% of children who ended up with organ dysfunction in the ICU. And I think showing that data to our clinical staff and showing us that we maybe weren't quite as good as we thought we were. And then we said, let's take a candidate tool that uses vital signs to help augment sepsis recognition. And would that have helped us find some of the patients that we missed? And it turned out that yes, we would have actually found not all, but most of the patients that we had missed clinically if we had a candidate alert in place. And so that evidence was kind of what we used to motivate us to say, can we build a tool that can kind of give us the best of both worlds? And so now then we built a 2-stage alert. So the first stage is based off of vital signs, so tachycardia and fever. And if you have tachycardia and fever, this kind of pops up for the triage nurse and asks you questions about, is there concern for infection, assess the perfusion, and then assess whether the patient has an underlying high-risk condition. And so if they have kind of fever and tachycardia and one other thing, so either altered mental status, altered perfusion, or an existing high-risk condition, then that calls us to do a kind of second screen alert where the clinical team is brought to the bedside. And as a clinical team, we assess the patient and say, do we suspect sepsis in this patient? Are we confident this is not sepsis, or do we need to think about it a little bit more? And this is kind of where the human piece comes in a little bit, where we as a clinical team, including physicians and nurses, kind of come to the bedside and make a decision on what the next step should be. And then the other part of this was that we do have the tachycardia alert kind of occurs once during the ED stay, and we didn't want it to kind of keep firing off because we were worried about alert fatigue. So we didn't want it to keep firing over time. So it goes off only once for tachycardia, but we were noticing that there were patients who kind of developed hypotension later in the stay that were not necessarily picked up by the clinical team. And so we do have a third stage of the alert that will come up for any new hypotension, and that kind of will track the patient throughout their ED course. So in terms of how often this goes off, because we really were worried about alarm fatigue, like I said, we see this is older data now. So at the time we were seeing about 96,000 patients a year, and that tachycardia alert would go off on about 16% of patients, and we would huddle, so that kind of clinical decision-making piece where the team comes to the bedside in 1% of patients. And this has been consistent now for almost 10 years. The performance of the alert works really very consistently. And in terms of those patients where we come to their bedside and say, should we kind of activate our sepsis protocol, that happens in about a quarter of patients. And again, this has been quite consistent over time. And then in terms of kind of how the alert performs, the alert itself is 86% sensitive. So it picks up, 86% of the patients that ultimately go on to have organ dysfunction, sepsis in the ICU. And then when we take into account, physicians are kind of allowed to call a sepsis huddle, even if the alert doesn't fire. So if you have a clinical concern about a patient, you can say, I'd like to call a sepsis huddle, even if the alert is not positive. And so when we take both of those elements and kind of combine them together, then our system works almost perfectly, but not completely perfectly. The other thing to note here is that the positive predictive value is pretty high compared to many other kind of published tools. So 25% we were pretty happy with compared to most other published vital sign-based tools in children have and less than 10% positive predictive value. And this is really kind of the money shot. So, are we actually is this tool helping us catch the patients that we want to be catching? And so the y-axis here is the proportion of ICU sepsis episodes that were missed in the emergency department. So patients who ultimately went on to have organ dysfunction and where we didn't find them. And you can see that we put the alert in place in 2014. It's been, going on now for almost a decade. And you can see that we improved pretty dramatically our capture rate of patients with sepsis when the alert first went into place, and that we consistently have our miss rate below 5%, which is great. We're pretty happy with this. Although you'll also notice that we really haven't been able to move it below 5%. So there are a lot of months in there where you can see we're at 0 missed cases. So it works quite well, but we have been really unable to get it down to 0. And that's where we're hoping that some of these kind of more modern tools will take us in coming years. But nonetheless, I think we were, if you remember back in the beginning, we were missing 30% of patients, and now we miss less than 5%. So we are pretty happy with that. And so, our tool has certainly been implemented in multiple other settings throughout the country, but there are other tools around. And I think really, many of these tools have not necessarily been compared head to head. And I think as long as you have a tool that works in your setting and that's been tested in your setting, the exact components of the tool at this point, I think, are probably less important than having something in place. This is a tool that was developed by Matt Eisenberg in Boston that is used a similar kind of point-based score for similar elements, vital signs, perfusion, mental status, and high-risk conditions. And their electronic tool, again, outperformed their kind of bedside clinician judgment. And their test characteristics are pretty similar to ours, except you'll notice that the positive predictive value is a bit lower. So in kind of thinking about, what can we do to make these tools better in the future? And are there elements that we can address that we have yet to really address directly? And one thing that I think that has been had significant attention in the last, few years, kind of in the setting of COVID and lots of other awareness around equity and care, is to say, can we use some of these objective tools to help us get rid of some of the implicit bias that we have in terms of caring for children across the US and really across the world. And I think we don't have answers to this necessarily yet, but this is just to note that, and this is US data saying that there have been longstanding disparities associated with sepsis outcomes, both in adults and children, kind of across race as well as across class. And this is an article by Dr. Reddy in 2022, really showing association with increased sepsis mortality, especially with insurance status as well as with lower household incomes, although there was also an association with non-Hispanic Black race. And so I think one question is, if we have some of these more objective tools that are based on vital signs, can this help us improve sepsis recognition and reduce disparities? I think that question remains to be answered. Although this was one project that we did in our setting, looking at our sepsis recognition tools with an equity lens. And so I mentioned before that there are two different ways to kind of get treated for sepsis in our ED. One is using the sepsis alert, and the other one is where physicians can kind of say, yes, I'm worried about sepsis in this patient, but the alert didn't fire, and I'm going to treat them kind of outside of the alert. And so we looked at those two different groups of patients to say, are there differences in performance of the tool or performance of our recognition tools by race? And what you can see here is that for the patients who got treated on the sepsis pathway when using the electronic alert, that there really were not differences in sepsis pathway activation. But for those patients that were activated outside of the sepsis alert, that we saw increased utilization of that tool in patients who are non-Hispanic white compared to those who are non-Hispanic Black. So again, this is suggestive and certainly not proven, but I think it's a tempting kind of hypothesis generating idea to say, can some of these electronic tools be useful in helping us to reduce disparities in care? So kind of pay attention to that in the coming years in the literature. The other thing is, I think, trying to think about, how do we know what we're looking for? And so some of the challenges, I think, of finding sepsis is knowing kind of, so for the patient who we fully resuscitated in the emergency department and they look great an hour later and, end up being admitted to the floor, not to the ICU, I think it's hard to know, did we kind of overcall? Did we pull the trigger and give them all these therapies that they wouldn't have necessarily needed? Or did we save their life with kind of early recognition? And so I think kind of building better surveillance definitions where we know objectively what was sepsis in the end can help us improve our recognition systems in the beginning as well. And so this is an electronic surveillance definition that we built to use electronic health record data to identify cases of pediatric sepsis. And I'm just going to show you briefly how we kind of applied that surveillance algorithm to study trends in pediatric sepsis epidemiology. And so this is an electronic health record tool that was used to identify patients with confirmed sepsis, so patients who had a blood culture obtained and who got at least 4 days of IV antibiotics within 2 days of that blood culture, and also who had evidence of organ dysfunction. And you can see the definitions of organ dysfunction here. And then we used that to both derive and validate this tool over 2 different time periods. And you can see that the sensitivity and specificity compared to a medical record review reference standard was decent, similar, in fact, to an adult tool that this was adapted off of. And so we then used this to track sepsis epidemiology over time. This was published in 2020. And you can see that kind of, at least in one institution, that we saw increasing sepsis incidence over time and really kind of stable sepsis mortality. And so I think this still needs to be validated in a multi-center fashion. And I think it's interesting to think about, why has sepsis gone up over this time period? I think one of our thoughts around this is that we are kind of taking care of increasingly complicated children. There are NICU survivors that last longer. There are cancer therapies like CAR T-cell therapy that allow kids to survive when they maybe weren't surviving before. And those children are vulnerable and at high risk for sepsis, and maybe one explanation why we're seeing increased incidence over time. This is just kind of a face validity of our tool, that you can see that as children had increased numbers of organ dysfunctions identified, that their mortality increased. And so, the next phase of this, I think, is thinking about, can we use even higher dimensional data? So our tool is based off of pretty simple, kind of what's your heart rate when you show up in the ED, what's your blood pressure, but we obviously collect a lot of data through the electronic health record. And can we use these kind of higher dimensional data and machine learning tools to make even better sepsis recognition tools? And so this is just one example that was developed by Halden Scott out of Children's Hospital in Colorado, looking at a predictive model of sepsis using even more granular data that's known at the time of hospital arrival. And you can see the performance of this tool is quite sensitive, a little bit less specific. And the predictors identified in this tool include things like vital signs, kind of more complex calculations around respiratory rate and shock index, and then includes some elements about whether or not there was an oncologic comorbidity, an indwelling central line, and a hospitalization in the last year. So I think keep your eye out for these. There's going to be more and more of these, I think, machine learning based tools that can help us hopefully to improve sepsis identification in the emergency setting, and also hopefully kind of hospital onset sepsis, which continues to be a big struggle, I think, and outcomes, in children with hospital onset sepsis are even worse actually than children with community acquired sepsis. So hopefully these tools can kind of help us in both of those realms in the coming years. And then the last thing I just wanted to touch upon is I do think that, I think we've learned through COVID and through lots of other things that virtual life and computers and high dimensional data are super helpful, but they're not the whole story, right? And really having a clinician at the bedside who can talk to a parent, who can really think about their interaction with other team members. What do our nursing colleagues bring to these questions? What do our learners bring to these equations? And how can we make sure that we take advantage of having a person at the bedside? Because we know that the machine is probably not sufficient to fully identify these patients in the most optimal ways. And so there's lots of elements. I think there's increasing ability to study kind of human factors in healthcare. And this is just one way to think about kind of how many dimensions there are to humans and how we interact with patients, and how do we bring some of these human elements to these computer-based tools. So I think this is just something else to kind of keep your eye out for in the coming years, to say, can we even use these human factors in a more evidence-based way to make these tools even better over time. And then the other last thing I wanted to touch on is to say, are all these fancy kind of tools, can we use them in low resource settings, right? And so it is true that a lot of these tools are based in the electronic health record, but the electronic health record is increasingly mobile. And I think a lot of these tools are available kind of on your phone. You don't necessarily need a big electronic health record to use them. There are kind of apps that you can plug into your phone. And so these are other things that I think we can really think about developing over time, is how do we take these tools, make them portable, have kind of ultrasound machines that you can attach to your iPhone. And I think there's a ton of possibility in the coming years to think about how do we adapt these tools for use in low resource settings, and thinking about things that are unique in those settings where sepsis prevalence is probably higher than it is in the United States emergency department. and thinking about how do we adapt tools in those types of places. The other thing to think about, I think, as we kind of try to augment our sepsis recognition tools is thinking about how do we build infrastructure at our institutions and how do we partner across kind of academic silos to help to make sure that these kids are taken care of regardless of where they show up in the hospital. And so we've been fortunate to have some really great partnerships, I think, between the emergency department and especially the ICU at CHOP to build a sepsis program here where we've kind of tried to integrate efforts in the emergency setting, in the ICU setting, and even kind of post-sepsis and their survivorship space that I think is kind of a whole other dimension that I'm not really going to talk about today, but in thinking about how do we improve care so that children, once we get them through this acute setting, can kind of thrive and reach their full potential once they leave the hospital. And so I would encourage folks to really kind of partner with people across the spectrum of care at your institution, across professions, and really take the opportunity to learn from each other in order to make care most accessible and most successful for children. So I will stop there. Thank you so much for having me. And I hope you have a great day.